Good afternoon. I don't have any relevant disclosures for this talk. So while this may not be common in vascular surgery practice, robotic thoracic outlet decompression has been a standard part of many thoracic surgeons' practice for more than 10 years. Unfortunately, though, while they may be very facile with the robot, they may have less understanding of the pathophysiology and the patient management. This is a technique that's been clearly demonstrated to be safe and effective in large case series, and it's appropriate for many but not all types of TOS. We've done close to 40 cases now at NYU. What we don't have time to discuss is the logistics of getting robotics privileges as a vascular surgeon, training pathway considerations, and the turf wars and politics of robot utilization. This is just a sample paper by Brian Burt, who is a thoracic surgeon. This is comparing robotic approach to supraclavicular approach for both venous and neurogenic thoracic outlet syndrome. Patients who had a robotic approach had lower pain scales and use of morphine equivalents, and robotic first rib resection was associated with less frequent total complications. I think most of us would argue that in experienced hands, any of these approaches is safe with overall low complications. Why bother? From my perspective, you get a much broader field of view. You can take out a larger portion of the rib en bloc. Patients do have lower postoperative pain scales in our experience as well, and the incisions are overall very small and hidden from view. With an experienced robotic team, this can also be performed very quickly. Our average case time is about 90 minutes. Surgeon economics are certainly a consideration, and it's definitely cool. So here's a sample picture from one of Brian Burt's papers, but I'll actually show you some pictures from some of our videos as well. You can see the borders of the first rib, and you can see how clearly you can visualize all of the relevant anatomy. These cases are done under general anesthesia with a double lumen endotracheal tube and single lung ventilation. The patient's positioned in the lateral decubitus position, and we typically use 4 ports, 3 robotic ports and an assist port for smoke evacuation. Generally speaking, we pace our ports along the 7th or 8th intercostal space, but we take into consideration the general shape of the patient's chest wall. The technical details, I think, are fairly understood from this technique, but we divide the intercostal muscle off the rib first, really define the edges of the rib, and usually the costal cartilage medially can just be divided using electrocautery. My preference is to divide the posterior aspect of the rib by hand using a Kerrison. I've used a variety of different long drill bits, but the Kerrison offers greater control and precision, and the drill bits have been on back order on many different occasions. You can easily perform partial anterior, middle scalenectomies, venolysis, neurolysis, etc. So this is actually some still images taken from a video of one of our cases, but you can see the level of detail and resolution that you get from the robotic platform. You can clearly see the mammary vessels here. You can see that the lung is deflated here. We're pointing to the first rib. This is after actually taking the intercostal muscle off and defining the borders of the rib, and anteriorly the cartilage has already been divided using electrocautery. Following removal of the rib, you can easily perform a robotic venolysis. Here, an anterior scalenectomy has also been performed. And the instrument in the left is actually a robotic DeBakey, which allows for some fine dissection using the robotic platform. As far as contraindications go, any patients who cannot tolerate general anesthesia or single lung ventilation can't safely have this operation. That includes severe pulmonary hypertension, dense pleural adhesions, recent MI, or unstable coronary disease. As you know, most of these patients are young and healthy individuals, so this generally doesn't apply to this group. Arterial TOS that requires vascular reconstruction is typically best performed through an open supraclavicular approach, and pectoralis minor syndrome cannot easily be performed using this technique, although that only applies to a subset of the neurogenic patients. These are some of the references I mentioned. I have a great interest in this topic and involving more vascular surgeons in this technique, so if you'd like to chat more about it, let me know.